You can see some risk factors for aggression here. These are the ones that are non-modifiable and are similar to risk factors for aggression in any population. History is the biggest predictor of the future, so history of violence is a really important risk factor here. Others include male gender, young age, mental illness, brain injury, and cognitive deficits. As we think of Ryan, he does have a history of violence. He's a young male. He has cognitive deficits. And while he doesn't have weapons training, which is listed here, he does have an interest in weapons, which is concerning for the people involved. There are also modifiable risk factors of aggression, which we might target with treatment and interventions. So you can see symptoms of mental illness here. You can also see a low global assessment of functioning, which is a score we use to evaluate the level of functioning from 0 to 100. It's used less now than it used to be. And then you also see access to weapons here and non-adherence to treatment. So these are all things we can modify. As we think of Ryan, he does have a history of hallucinations. He has a history of non-adherence to treatment, and he does display impulsivity, depression, sometimes hopelessness, and suicidality. I want to mention protective factors as well. Connection with others, a good support system, and engagement in activities can all be very important protective factors. These may not look the same for all individuals. Adherence to treatment might include medications, therapy, and behavioral plans, and that can be very helpful for sure. A positive attitude can go a long way. I have one patient who has a lot of risk factors and a lot of trauma in her past, and she's often reacted aggressively, but she's been able to develop some important connections and has a really positive attitude toward herself and others. She calls herself a strong, independent woman, and I really credit her attitude and her supportive team for the huge leaps that she's made in her treatment. As we think of the written case, Ryan has a good support system in his parents, and he is currently adherent to treatment. So this is a scale, the Modified Overt Aggression Scale, which is developed for kids to track aggression, but has been validated in the ID population. This could be used to monitor severity of aggression over time and measure efficacy of interventions. I know when we're in kind of the thick of things, it's hard to be objective about kind of the level and severity of aggression sometimes. So this scale can help providers kind of track over time whether interventions are working or not. There are certainly some special considerations for those with ID. Those with moderate to severe ID are at increased risk for aggression toward others. Those with severe to profound ID are at higher risk for self-harm. Aggression is often a means of expressing frustration or some other form of communication. We should not overlook grief and loss, emotional or physical pain, and the changes and stress going on around the individual. This actually might include things that you think the individual doesn't know. For example, there might be an increase in aggression when parents are getting a divorce, but maybe they haven't told the kid, either the child or adolescent or their adult child, but they haven't told them about the divorce, so they don't think that's contributing to the increase in aggression. But there has been a big change in the family life that the kid can probably feel. So even those things are important to consider. We certainly consider aggression to be a symptom of something else. And we often need to look for the underlying cause, whether that's physical, psychiatric, or a response to a situation. So we know of some biological risk factors for aggression. This is a summary. There are references at the end. Family history is a big risk factor. Aggression may have a genetic component or be learned. And of course, with family history, you consider PTSD as a contributor as well, which also has biological risks in itself due to changes in brain structures with trauma. In general, we know serotonin plays a role, and many of these listed here have to do with serotonin and the receptors for serotonin. Norepinephrine, dopamine, and GABA are also neurotransmitters indicated in risk for aggression. So disruptions or alterations in the pathways can be contributing factors. The prefrontal and frontal cortex are involved in decision-making, planning, organization, impulse control, and emotional regulation. So dysfunction in those areas can be associated with the increase in risk for aggression. Other areas of the brain, such as the temporal lobe and the amygdala, which has to do with response to fear and danger, could be indicated in risk for aggression as well. The brain uses glucose and other nutrients are building blocks for our brain. So these things are considerations. And then we notice that there are EEG abnormalities in about 25 to 50% of violent criminals. So that's change in brain waves and brain functioning. So there's plenty of biological risk factors. That would also include psychiatric risk factors. Psychiatric disorders do put individuals at higher risk for aggression. Also remember that individuals with mental illness are more likely to be victims of violence, so it's not just putting them at risk for being aggressive, it's also at risk for experiencing aggression. These risk factors include substance use, psychosis, mood disorders, personality disorders, behavior disorders, and delirium and dementia. Patients with threatening paranoid delusions are about twice as likely to be aggressive, and up to 30% of patients with dementia are aggressive. Patients with ID may use aggression to communicate. You're going to hear me say that over and over again during this talk, and that may include communication regarding distress related to a psychiatric illness. Other medical things we would consider as contributing factors are listed here as we move forward to the biopsychosocial formulation.